Good morning. Thank you for your patience. We're waiting for our Senate colleagues to join us, and due to the current pandemic, about half the folks of my colleagues that were scheduled to speak this morning have to take other precautions and not be here, and we understand that. But I appreciate everyone for being here. My name is Kalra, California State Assembly member representing the city of San Jose. Over the last 2 years, and as we continue to endure a worldwide pandemic, one thing continues to remain clear. Our healthcare system is broken. The connection is clear, as roughly 1 out of every 3 COVID deaths are linked to health insurance gaps. And sadly, it runs much deeper than that. We know that accounting for the first year of the pandemic, Black life expectancy dropped 2.7 years, and Latino life expectancy dropped 1.9 years. But this isn't just a COVID thing. Unfortunately, it's an American phenomenon where health outcomes are so connected to wealth, employment, and where you live that it inevitably leaves those in our community that are traditionally disadvantaged at greater risk of bankruptcy, sickness, and death. The reality is that our healthcare system has been broken for decades and has gotten increasingly more costly, with Californian workers and employers more and more picking up the tab of spiraling out of control costs. This is not the norm anywhere else but here in our country. We have by far the most expensive healthcare system in the world, with the worst outcomes of wealthy nations. We are 46th in life expectancy. We rank last in maternal deaths of industrialized nations. And we rank first in medical bankruptcies. In most countries, that doesn't even exist. But none of this is news. This has been the case for far too long, and we've come to accept it as the norm. We've come to accept hundreds of thousands of Californians going bankrupt and tens of thousands dying because of lack of meaningful access to health care. There are countless studies that tell us a single-payer healthcare system is the fiscally sound thing to do, the smarter healthcare policy to follow, and a moral imperative if we care about human life. Now, we know that the likelihood of single-payer healthcare legislation happening in Washington, D.C. at this time is beyond unlikely. However, states can do it. As we stand here, New York State has legislation, Washington State is looking at legislation. We're California. We can show the rest of the country how to take care of one another and create a healthcare system that focuses on patients over profits. Will it be easy? Of course not. There's a reason this has been tried and failed many times before. The status quo is powerful, and those who benefit from it are extraordinarily wealthy and influential. But we are not here to represent the upholders of the status quo. We are here to represent those who are suffering, those who are begging us to follow a more righteous path. With AB 1400, we will create a transformative policy that establishes CalCare, a single-payer healthcare coverage system in California for all residents, by stripping away the tens of billions of dollars of administrative costs in our current multi-payer system and lowering per-patient healthcare spending. We can guarantee quality, comprehensive healthcare and long-term care without barriers to care or out-of-pocket expenses. Freeing of choosing your provider without worrying about being in-network or not. Equitable care, not a multi-tiered system, depending on whether you have private gold-plated insurance, covered California, Medi-Cal, or other publicly subsidized insurance. Long-term care, which most Californians currently have zero access to. Special projects budgets to deal with healthcare disparities, particularly in rural and underserved communities. This can all be a reality if we fight for it. This morning, I, along with many of my colleagues, introduced an Assembly constitutional amendment, ACA 11, to not only resolve constitutional issues regarding setting up the CalCare system, but also address how we bridge the gap to funding that will exist once employer and worker premiums, co-pays, deductibles, and other costs are eliminated, and we're able to move state and federal funds into the CalCare fund. ACA 11 proposes various taxing mechanisms that will cost Californian employers and Californian families far less than what they're currently paying for health care. There's oftentimes an obsession with the word tax. But if the question is asked, how are we going to pay for it? It will be irresponsible to refuse to first ask, how are we paying for our current, most expensive system in the world? How much do we pay in costs? in stress, in lives. Californians are already paying enormous amounts of their money for health insurance, if they have any at all. The public financing options suggested today are only a fraction of what current Californians and employers are paying for. For example, the average employer pays 9.9% of payroll for health care. Under ACA 11, that number would drop to 1.25%. A worker making $75,000 a year currently averages paying 2.5% of their paycheck, or $1,875 in health care. Under CalCare, that number would drop to $250 a year with no deductibles or copays. This is not rocket science, it's plain math. It's time we join the rest of the world and move away from employer-based health care. With a two-bill strategy, we have time to debate the funding mechanisms while allowing the policy bill to continue moving forward. In fact, in October, when I traveled to Washington, D.C., and I met with the Deputy Director for Policy overseeing Affordable Care Act waivers for the Health and Human Services Agency, he and his team made it clear that a state needs legislative authority to begin the federal waiver process. That means it needs to pass a bill. However, funding does not need to be determined at the same time. And why? Why is that? Why does that make sense? Because the waiver process will first inform us how much money we will be getting from the federal government. That, coupled with our existing state resources used for healthcare, will give us the amount necessary to sustain the CalCare system. I want to sincerely thank Speaker Anthony Rendon and his team for meeting with me, my team, and the sponsor over the past several months. We would not be here without their willingness to engage and their time and energy put into this. I also want to thank Health Committee Chair Dr. Jim Wood. This morning, I'm so excited that AB 1400 got referred out of rules to the Health Committee. And I'm looking forward to having a hearing on AB 1400. Thanks to Dr. Wood's commitment and his staff's diligence, I know it'll be a fair, transparent, and productive hearing for all of us to take part in. I want to thank our co-authors of AB 1400. And I want to thank our co-authors of ACA 11. Our co-authors of AB 1400, joint authors, Senator Lee and Santiago, again, both couldn't be here. Principal co-author, Senator Lana Gonzalez, Senator McGuire, Senator Ting, Senator Wiener, Assembly Members Bryan and Carrillo. Co-authors, Senator Becker, Cortese, Senator Friedman, Senator Comlager and Laird, Senator Bonta, Senator McCarty, Senator Nazarian, Senator Luce Rivas, Senator Wicks, and Senator Wykowski. And for the ACA 11, co-authors, Senator Carrillo, Bonta, Senator Cortese, Senator Friedman, Senator Gonzalez, Comlager, McGuire, Senator Nazarian, Senator Santiago, and Senator Wiener. I think it's important for us to name the names of those who are standing for all Californians and health care access for all. And I want to thank our sponsor, the California Nurses Association, who's been a tremendous partner in this effort and has been so persistent over so many years in the fight for single-payer health care. I'd like to now introduce Stephanie Roberson, Government Relations Director for the mighty California Nurses Association.
Good morning, everyone who is present, and thank you so much to Assemblymember Kalra, the principal author of this bill. We have been in the trenches together for the last year or so on this issue, and obviously he and I talking about the road to single payer much longer than that. So I want to it's a special pride and privilege for me to work with Assemblymember Kalra and his team, his legislative team. I also want to thank Assemblymember Wendy Carrillo. To my left, we also have talked about this issue for many years and how we resolve crises in our communities as it relates to Black and Brown communities. Specifically, Assemblymember Phil Ting, working closely together with him, solving crises and workforce issues as well. And of course, Senator Dave Cortese, working on parity issues. I feel very privileged to stand in front of these legislators on those broader issues, but namely single payer today, and of course all the co-authors that Assemblymember Kalra mentioned. And I would be remiss to not mention our Medicare-for-all CalCare policy team, our national policy teams, our MFA ground team, our communications team. We have brought in so many people to this movement, so many more millions of volunteers texting, speaking to all of you, to the people, to the communities about how critical we need to bring comprehensive health care to all Californians. And so the time is absolutely now. COVID has absolutely shown us that the need is great. As Assemblymember Kalra said, it's not just a COVID thing. This is a people thing. This is a point of ensuring that people are not dissuaded from accessing quality health care because they don't have the ability to pay. And so that's what we're here to do. And so, we believe that, there is one guarantee. If we don't pass this bill, that out-of-pocket costs for Californians will continue to sharply rise. And we believe the time is now to guarantee health care for all. There should be no need to make choices over food, gas, sustenance like that. We've seen the uptick of GoFundMe accounts. We are Californian. We are California. We are smarter than this. We are better than that. And I know the legislators behind me care about this state and the welfare of their constituencies. And so we know that it is incumbent with all of these colleagues here that they will impress upon the broader body to continue to care for California, to continue to make the health, welfare, and safety of all Californians a top priority in the state. I also want to throw a few stats, and I think Assemblymember Kalra mentioned that. We're heading into the 2022 midterm elections, and we know that nearly half of U.S. adults list out-of-pocket costs for medical care as their top economic worry. A mid-December survey by the Kaiser Family Foundation reported this. 1 in 7 Californians skipped, delayed, or cut back care in 2020, 60% of them because of costs. 1.3 million households in California have medical debt collections. More than Black and Latino Californians self-rationed need for care due to cost or insurance barriers more than whites, according to a September UCLA health policy brief. Among Latinos, 40% of those who postponed or skipped care due to the high cost, with another 15% citing system barriers. Many of them are among the 3.2 million in California who remained uninsured to this day. So I can go on and on here. We are making the case. I am so happy that we have this companion bill that will answer the questions moving forward on how to finally get this done, but we can't let this stand. If I can cite a couple of more stats about employer-paid insurance, we talk about employer-paid insurance and how we're going to bring that down, but that also isn't always enough. 45% of Californians pay more than 25% of the premium for single coverage, reported in the California Healthcare Foundation in August. 70% of workers in companies employing 199 workers or less face annual deductibles of at least $1,000 for single coverage. A fourth of insurance plans require a deductible of over $2,000 or more, and that's doubled since 2012. In the past year, 14% of California firms reported they increased cost sharing for their workers, and they're not done. Nearly 40% of California firms say they're likely to demand premium increases in this year. 28% expect to raise deductibles in 2022. So that's what we can expect here in 2022. We can expect insurance, healthcare to rise in costs. But what we are demanding is healthcare for all. And with this bill and with these legislative colleagues behind me, we can get this done and finally provide the care that all Californians need. Thank you so much for being here. And I would like to turn it over to Assemblymember Wendy Carrillo. Thank you very much.
I will keep my remarks short. I'm doing both English and Spanish. Good morning. My name is Wendy Carrillo, and I'm proud to represent my community of Northeast LA and East Los Angeles. There are 120 legislators in this building that impact the 40 million people that call California home. We have done historic things related to healthcare, including eliminating the medical assets test that threatens the financial stability of seniors and Californians with disabilities. And we have expanded Medi-Cal to include not only children and youth, but all Californians over the age of 50. And in this last legislative cycle, we were able to include undocumented seniors across our state of California. And I think that's historic and impactful and took years to do, but it is not enough. Today, I join all of you again to continue the work as co-author of AB 1400, authored by my colleague, Assemblymember Kalra. Human rights are inherent to all human beings, regardless of race, sex, nationality, ethnicity, language, religion, or any other status. Guaranteed healthcare for all is inclusive in all of those rights. Healthcare is a human right. The COVID-19 pandemic has exacerbated health inequities and made it very clear that access to healthcare is truly a life or death issue. More than 70,000 people in our state alone have passed away because of COVID. Immigrant communities, low-income communities, Black and brown communities have suffered those consequences the most, beyond anyone else. And unfortunately, the pandemic is not over. New variants have emerged. Thousands are still getting sick from the virus. And tragically, there are those who are still losing their lives. Our essential and frontline workers and underserved communities are underrepresented in not only COVID cases, but in mortality rates and long-term complications. California must lead by keeping the promise of a California for all, because healthcare is a human right. And let me say that again. Healthcare is a human right, and together we will make it a universal reality for everyone in California, everywhere across our state, without exception. That is the monumental moment that we are in our state today. Let me just say a few words in Spanish. Buenos días, mi nombre es Wendy Carrillo, orgullosamente representando la comunidad del noreste y el este de Los Ángeles en la Asamblea Estatal. Es un honor estar aquí con ustedes. Es un honor trabajar en este edificio con 120 legisladores, bueno, 119, yo soy la 120, para poder pasar leyes que impactan las comunidades a través de nuestro estado. Hemos eliminado la prueba de activos de medical que amenaza la estabilidad financiera de las personas mayores de edad y personas con discapacidades, y haber incluido medical para incluir no solo a niños y a jóvenes, sino a todos los californianos mayor de 50 años, y este año también independiente de su estatus migratorio. Hoy me uno nuevamente con ustedes para continuar el trabajo que nos espera con la legislación AB 1400 de mi colega, el asambleísta Kalra. Los derechos humanos son importantes y todos los seres humanos son independientes de su raza, sexo, nacionalidad, idioma, religión o cualquier otra condición. Nuestros derechos incluyen la atención médica garantizada para todos. En el estado de California, más de 70,000 personas han fallecido por el virus de COVID. Y sabemos que estas comunidades son comunidades inmigrantes, de bajos recursos, latinas y afroamericanas. La pandemia de COVID-19 ha empeorado las inequidades en la salud y ha demostrado que el acceso a la atención médica es verdaderamente un problema de vida o muerte. Desafortunadamente, la pandemia no ha terminado. Han surgido nuevos variantes. Miles todavía se enferman por el virus y trágicamente hay quienes aún todavía pierden la vida. Nuestros trabajadores esenciales y las comunidades sobrerepresentadas, no solo en los casos de COVID, sino también en las estadísticas de la mortalidad. California debe seguir siendo un líder y mantener la promesa de un California para todos, porque la atención médica es un derecho humano. Lo voy a decir otra vez en español. La atención médica es un derecho humano. Y juntos vamos a convertir esta ley en una realidad para que todas las personas a través del Estado tengan acceso a poder ir a ver un doctor sin excepción. Muchas gracias. Now let me take a moment to introduce the chair of Senate Labor Committee, Senator Cortese.
Thank you, and thank you all for being here. I'm very, very proud to be a co-author of AB 1400 and the rest of these efforts as announced today. There's an old slogan in politics and government, which is keep pushing until you meet resistance. In this case, the author, our leader on this bill, Assemblymember Kalra, has indicated we are going to keep pushing not just till we meet resistance, because we've already met resistance, but until we're stopped. And the reason we're not going to be stopped is because this is a smarter effort in the past. And the effort to move out constitutional obstacles ahead of time is smart. That hasn't been done in the past. The effort that Assemblymember Kalra was speaking about in terms of making sure that federal funding is identified before state appropriations are locked in is a smarter effort than in the past. And I just want to commend Assemblymember Kalra for his discernment on charting the path for all of us to get to where we want to go. This wasn't a hard decision for me to support this bill because my county, Santa Clara County, which is the second largest public health and hospital system in the state of California, has taken a position supporting universal health care since prior to the Affordable Care Act and consistently done so. And I've always been a leader in my own county in that respect. So it's natural for me to support this cause. It's natural for me to do everything I can to make sure we're successful and, again, that we're not stopped. We need to demand more from our healthcare system. As has been said by my colleagues in the legislature already today, the pandemic has drawn that out. And I think, again, that is another reason why ultimately we won't be stopped, in that this effort will be embraced not just by legislators and not just by those who have to define the California state budget, but by the public at large. So it's time for us to continue to show up, to speak out, and to demand health care as a human right, and health care as a human right here in California. And with that, I'd like to introduce the chair of the Assembly Budget Committee, Assemblymember Phil Ting. Thank you.
Thank you, Senator. I'm really proud to stand with you, but also our author, Assemblymember Kalra, as well as Assemblymember Carrillo, and of course, our great friends at the California Nurses Association to really talk about our healthcare system. Someone once said that the definition of insanity is to do the same thing over and over again and expect a different result. And I can't imagine a more apt description of our healthcare system. Mr. Kalra talked about a system where we spend more than any other country, any industrialized country in the entire world on healthcare, and yet across every single indicator, every single public health indicator, we get the worst results. So why are we in a situation where we actually think that more money would solve the problem without systemic reform? I'm proud that we are part of a state. We actually have 92% of our citizens and our residents here in California fully insured. It's a great step, a lot of that because of the healthcare expansion by the Affordable Care Act. But we are a long ways away to getting that final 8% through the finish line. And it's really only a system like AB 1400 where we have everybody who can have access to insurance regardless of whether they can pay for it or not, regardless of whether they can afford it, regardless of what their status is in this particular state. It's only then when we have a universal system where everybody can have access that we can actually that we can actually be proud of a healthcare system and have a better result. We need a healthcare system where costs are cheaper. We need a healthcare system where there's greater access. We need a healthcare system which has greater value of its workers, every single worker in that system. And we need a system which really puts patients first. And what you have is a system that is very expensive. We have excellent care, but only for those who can really afford to pay for it. Only with a system that AB 1400 envisions, where everyone can have access to the same healthcare outcomes and the same healthcare providers, will we be able to really expect a different result. That's why I'm proud to be a principal co-author of this legislation. I'm proud to have been a longtime supporter of single payer. The time for single payer is now. We've seen in a pandemic how important healthcare access is. What did we do when we entered a pandemic? We'd make sure that people had access to vaccinations. We had to make sure people had access to medication. We made sure that people had access to healthcare. But it really took a pandemic to get us to that point. So now that we've seen what the answer is, we need to put that we need to prescribe that answer for our state, for our country, as we come out of this pandemic, and make sure that the lessons that we've learned for this last 18 months is ensuring that we have health care for all. And with that, I'm going to turn it back over to our great author, Assemblymember Ash Kalra of San Jose, and I'm sure he's happy to take any questions.
I'm very grateful to all my colleagues. When you have the budget chair on your side, the numbers are good. But all my colleagues here, Senator Carrillo and Ting, Senator Cortese, my dear friend from San Jose, who I can attest to the fact that he's been at single-payer town halls, rallies, and support for well over a decade. And of course, Stephanie Roberson and our powerful partners and with the California Nurse Association. I also want to thank Speaker Anthony Rendon once again, as well as Chair of the Health Committee, Jim Wood. And in 2018, then candidate for Governor Gavin Newsom famously said, "I'm tired of politicians saying they support single payer, but that it's too soon, too expensive, or someone else's problem." I agree. This is our problem. Doing nothing is not inaction. It is, in fact, the cruelest of actions while millions suffer under our watch. I, for one, would not be able to look myself in the mirror knowing that I had the opportunity to bring justice, morality, equity, and common sense to our healthcare system and didn't do it. And, we have enough of this gaslighting going around, folks trying to convince us that we're crazy, when the reality is our current system is insanity. And they may tell us, don't look up, but we're going to look up, and we're going to look at everything that we can do to bring justice and end this tragedy. Because I refuse to pass this tragedy on to the next generation without a fight for something better. So years from now, there isn't another press conference like this one after so many more Californians unnecessarily suffered. Healthcare is a human right. It's time that California shows the rest of the country what that means. So thank you. I'm happy to answer any questions you may have. I can hear you. I can hear you. Want me to step a few feet closer? I can probably hear a little better. Thank you. Yeah. So there's two bills, as you correctly stated. There's the policy bill, AB 1400, and there's the funding/constitutional issues bill in the ACA 11. Now, by having two different bills, it allows us to continue to push forward AB 1400, the policy bill. Whether we have the votes in the Assembly or not, that's something that, I think will soon be revealed, but we first, one thing at a time. Right now, it's being referred to Health Committee. I feel confident I know for sure we're going to have a well-run hearing with Chair Wood. I've always had great experiences bringing healthcare bills before that committee under his leadership. And I feel confident that we can get it through Health Committee. Again, that's going to be up to the individual members to make that decision. I've got to make the case. My colleagues have to make the case. But even then, I recognize that this is not an easy task to get it through the Assembly by the end of the month. But I think it's absolutely doable. I think that it's about political will, especially given the fact that we now have a separate vehicle for funding that gives us more time to delve into that. That doesn't have to be out by the end of the month. We have weeks and months to really dive deep into those issues. And frankly, given the process of the federal Medicare waiver process, they actually make that same suggestion that you have to get a policy passed, and they don't require that funding is determined ahead of time, because it kind of puts things in the reverse order, because we need to know what we're going to get out of the federal government. Keep in mind that as of 4 years ago, the numbers are probably even higher now. Over 70% of our healthcare is already paid from some form of public finance or public incentive. And so now, given the amount of money we pumped into it over the last couple of years, it's probably even more than that. So we're talking about the delta that we have to come up with as well. But we won't know what that delta is until we start going through the Medicare waiver process. I don't, it shouldn't make it a harder decision for my colleagues, because in AB 1400 itself, it says it does not become operative until the funds are made available. So we can debate the policy, but if someone says, oh, well, how are we going to pay for it? Or I want to see how we're going to pay for it. Well, those are two different issues now. We can have that full debate on the policy, and now we can also have the full debate on the financing. But one should not prevent the other from being discussed, voted on, and moved forward. There's no other state that has implemented it. I know that there was a point at which Vermont did get a Medicare waiver for a single-payer program. They weren't able to figure out the financing once it came back on that. And that's why we don't want to ignore that, right? Even though we're talking about parallel tracks, that the funding aspect of it could trail the policy, we don't want it to be at a standstill. And that's what happened with Vermont. They actually did get a waiver for a single-payer program, but they didn't have the financing worked out and had to abandon it. And at this point, there's no one else that has it. New York State does have a bill that's in the legislature right now. Washington State, I believe, has a proposed bill. I'm not sure where that is in the process. That's correct. That's correct. And I think if we can agree on a policy and get a policy passed and start the Medicare waiver program, then it becomes more real. Then you're actually telling the voters what they're voting for, and that's really important. Sure. No, and I think that we have to kind of change the dialogue here, because the reality is that the first question that should be posed to those voters is, how are you currently paying for your health care, and how much are you paying? Because the reality is we are paying more than anywhere else in the world for our health care. That's now. And so we can get caught up in semantics, so there's going to be this tax. At the end of the day, you're paying less. And so that's the critical point. And so I think that it's going to be education. We know that, look, we know that that's where the opposition is going to hinge, their energy on, oh, look, a tax. What the opposition doesn't want to tell you is how much they're charging you right now for health care, how much you're paying. Right now, employers are averaging, if you're making between $50,000 and $100,000, your employer is paying 9.7% of their payroll costs for health care, 9.7%. We're going to bring that down dramatically. And so we have to figure out the delta between the publicly funded aspects of our healthcare system and keep in mind, getting rid of premiums, of deductibles, of copays, not just for the worker, for the employer too. So if you're an employer saying, man, I'm paying all this for healthcare, get rid of all that, and instead, here's a 1.25% payroll tax. I think that's a hell of a bargain for employers, and even a bigger bargain for the workers. The pandemic, I think, is the absolute time that we have to have this introspection and recognize that our healthcare system has been failing us for a long time. It's been exposed more clearly than ever before. And so this is absolutely the time to do it when people have been suffering, when we're sending people back to work. And, our healthcare workers are leaving the industry. This is the time to do it. This is the time to do it, because this is the time where most Californians will agree that our healthcare system is broken. It's not a fault of the nurses, the doctors, the healthcare professionals, the first responders. It's not their fault. This has been created over decades, and it's cemented. We have to break up that cement. We have to create a new system and let a new system sprout out, because this pandemic, I think, has shown us what happens when we don't. And that's why we've been so ill-prepared in this pandemic. We've lost so many lives, so many, disproportionately those that were uninsured. And let's keep in mind, CalCare also funds long-term care. Think about the tragedy in our long-term care system. Most Californians do not have long-term care. If an elderly family member needs it, a family member has to leave their job or pay, use their savings, take out a second mortgage to pay for care. That is not sustainable, it's not smart, and it's immoral. So on the second question, it does not require an act of Congress. When I met with the representatives of the Health and Human Services, we asked that question very clearly. Do we need any legislative action from Congress? They said no. On the first question, yes, absolutely. Medicare, Medicaid, Medi-Cal, we currently are spending hundreds of billions in publicly financed programs for our current healthcare system. So we're just talking about the delta. I think that the taxation mechanisms put forward more than make up for that delta. But those are the kinds of conversations and kind of analysis that will be required. But based upon information that we've seen, including the analysis of SB 562 4 years ago, because there was some in-depth analysis then of it as well. I believe that what we're putting forth will be enough. But again, that's also a part of allowing ACA 11 to be separated from the policy, because it does require that further in-depth analysis. Well, there wouldn't necessarily be a need, because if you already have insurance and if you already have care and you've already paid for it through the different taxation or through Medicare or what have you, Medi-Cal, now you're having all come into one. Because what we have now is a multi-payer system. What we're trying to do is get rid of these dozens of buckets of funding, whether it's private insurance, whether it's employer, whether it's Medi-Cal, put it into one bucket. If that one bucket is now paying for your health care and you can still choose whatever doctor you want to go to, whatever hospital you want to go to, there's no need to have to get private insurance. Now, there's the countries that do have single payer type programs. They do allow for supplemental if you want luxury service and, or things that are non-essential, cosmetic, what have you. There's nothing that stops private insurance companies from offering those types of supplemental services. But in terms of comprehensive care, there's no need. And frankly, right now, those that have private insurance will have worse coverage than what CalCare will be providing. So you can, I don't see what the appeal is. Right now, we are to have a private insurance, have private insurance coverage that denies requests all the time from doctors and from patients for care, that doesn't provide long-term care, that doesn't provide so many things. CalCare will provide those things. So there's really just no need to go outside of the CalCare fund. And it's interesting because oftentimes folks are like, well, I have my insurance. What if I like my? At the end of the day, people like their doctor. They like the community clinic. They like the nurses when they go to the hospital. I don't know anyone that likes their insurance companies when they're on the phone for an hour trying to get some prescription covered, or trying to get their copay, or trying to get their bill reduced. What we're trying to do is get rid of the cumbersome aspect and costly, as much as 20%, costly administrative costs, and instead streamline the payment system so that you spend more time with your doctor, your nurse, your doctors. You talk to doctors. The reason why more than half doctors now support a single-payer healthcare system. If you talk to doctors who have been practicing for 20, 30, 40 years, they're spending way more time on the phone with insurance companies with their patients. I've experienced it. You probably all experienced it when you go see your doctor. Do you spend more than 2 or 3 or 4 minutes with them now? When I was younger, 20, 30 years ago, you might actually get 10, 15 minutes. And so we're trying to actually make the quality of life of healthcare professionals better too. Anything else? All right. Thank you, everyone.